I'd like to thank Dr. Bavaria, Dr. Budwani, and Prachance for this beautiful opportunity to have a CTSNet roundtable discussion at this very excellent meeting, the North American Aortic Valve Repair Symposium. We are in Philadelphia today, and it's a beautiful city. And just to set the scene before we kick off, we've heard a lot about bicuspid aortic valve related aortopathy and the things that people innovate in terms of operating on bicuspid aortic valve patients in terms of valve repair and aortic valve replacement or aortic root repair and replacement. There are surprisingly little data in the current literature that definitely track the incidence of bicuspid aortic valve related aortopathy and its complications, in particular to aortic dissection. In this time and age, definitive surgical recommendations based on aortic diameter are not robust and good enough. And for this reason, we've lined up today for you an excellent panel. It can get better than this. I've got on my left-hand side Dr. Joe Bavaria from the Hospital of University of Pennsylvania. And also next to him, I've got Dr. Joe Caselli from Texas Heart Institute, Baylor College of Medicine, Houston. And also next to him, I've got Dr. Munir Budwani from the University of Ottawa Heart Institute. And also next to him, I've got Dr. Jibril Khoury from the Clinique Universitaire, St. Luc, Brussels. I hope I'm getting it good this time in French. And next to him, I also have got Dr. Thomas Gleason from the University of Pittsburgh School of Medicine. And next to him, I've got also Dr. Edward Chen. And Dr. Edward Chen is from Emory University Hospital in Atlanta. And also next to him, I've got Dr. Himanshu J. Patel from the University of Michigan Health System, Ann Arbor, Michigan. And also Professor Hans Heinrich Siever from the Clinic for Cardiac and Thoracic Vascular Surgery, Lübeck, Germany. Thank you very much all for joining us. I'm going to kick off by a question to Munir. We're going to take things back to the basics. We've had a lot of controversies on how do we approach things. I'm sure the viewer on CTSNet would like to know. Munir, the question is, what is the relation between bicuspid aortic valve and aortic dilatation?
That's a loaded question, obviously. We can use the rest of the time of the panel to just talk about that. Well, I think there's certain things we know and there's a lot of things that we don't know. I think we all agree that it's a combination of factors that links bicuspid aortic valve disease to aortopathy. There are hypotheses that link hemodynamic factors to aortopathy, and there are hypotheses that link molecular and genetic factors to aortopathy. The reality is that it's probably a combination of both and different players in different patient populations or subpopulations that occur.
Great, thanks for this burst of answer. Munir, I'm just going to turn the question now to Edward. Ed, is hemodynamic burden in bicuspid aortic valve a main contributor to aortic dilatation?
You know, I'm not sure we really know the answer to that, to be honest. Certainly there's a lot of theoretical postulation about the post-stenotic dilatation, the hemodynamic stress, but combined with the aortopathy, the inherent flaws in the integrity of the tissue. But whether we can say that with how much that contributes from a quantitative level is difficult to say.
Great, thanks, Edward. Professor Siever, is there an elusive link between aortic wall histology and echocardiographic anatomy in bicuspid aortic valve? Is there an elusive link between the aortic wall histology and echocardiographic anatomy in bicuspid aortic valve? Or should I just rephrase it? Can this have an implication on a prophylactic surgery? So basically, if the anatomy of the aortic valve as seen in the echocardiography or as known from the histology, could we move on to have a prophylactic surgery on the patients based on these two factors?
Yeah, you mean if there are any echocardiographic
Yeah.
signs that
Yeah.
I do not think that there are any echocardiographic signs that you can remove the ascending aorta prophylactically. I think it depends on a lot of other factors. First of all, I think it is the size that determines if we replace the ascending aorta, and this again is related to the age of the patient. I think it's very important to relate the size of the ascending aorta to the age of the patient, and the most important question is how can we see from outside the patient if there is any need to replace the ascending aorta. And at the moment we don't have any factors that tell us which wall histology is frail, or why we should replace the ascending aorta. I think there is a very interesting biomarker coming up, and this is a glycation end product as shown in the presentation from Philadelphia. And I could expect that in the future we will have some biomarkers telling us that there is some weakness in the ascending aorta, and then we have more ground to do a prophylactic replacement of the ascending aorta. And I'm very eager to see what's going on with this biomarker.
Thank you, Professor Seaver. Dr. Bavaria, Professor Seaver mentioned something about the aortic size. He touched base on the sizing, although the guidelines now keeps changing with subcommittees meeting for a review on the previous guidelines that were published in the past. My question to you, is diameter of the ascending aorta in association with bicuspid aortic valve a reliable measure? Should we go with what Professor Seaver just mentioned now?
Well, I think that the size is what we have. It's the easiest thing to measure. It would be nice to have some other things that we can measure to help us determine whether somebody should get their bicuspid aortic valve aorta replaced. For example, it would be nice to have either CT-MR or some other imaging, echo, some imaging method to be able to determine what the wall thickness is, because that would give us a better index of what the stress equation would be for these particular aortas, because wall thickness is very important, and wall integrity is as a marker for wall thickness, such as a Marfan's patient may have a very thin wall, and AI patients have thinner walls than AS patients, for example. So it would be nice to have that, but we don't have that level of clarity at this point. So the other issues that might help us would be genetic testing, which I think is coming around. It's not there quite yet, but there's a whole bunch of different genes that we may pull the trigger for earlier aortic replacement if they're positive, such as SMAD3 and ACTA1 and things of that nature. I do, however, believe that the diameter is kind of crude. We know for a fact that there's many dissections at 4.5 centimeters, for example, so that the guidelines are not perfect and would not, not to take into consideration those kinds of patients. Although that is living in the denominator and not so much the numerator, which is a very important concept. So diameter is is what we have, but it's certainly not everything that we need to know. And as Dr. Sievers pointed out, and many others, including in the guidelines, I personally believe that we need to modify the diameter issue for our patients. For example, he was talking about Z scores and things like that. I really do believe that BSA measurement, which the Canadians have shown us in their guidelines, that aortic diameters related to BSA are incredibly important and maybe a lot more important than diameter itself.
Thank you, Dr. Faria. That's excellent. Dr. Caselli, faced with an 18-year-old female patient who has an aortic regurgitation and an ascending aorta, which is 4.2 centimeter. What's your take on that? How would you approach this patient? Would you replace the valve with a Bantal and you will sort the ascending aorta, or will you just go ahead with the valve alone and wait for a later stage, given your extensive experience in aortic surgery? What's your take?
Yeah, well, our general cutoff in a young patient like that's about 4 centimeters, where we begin to address the aorta if we have to be there for the aortic valve. And I think in a situation, the kind of case you just described would be probably very minimal to a David reconstruction and then replacing the aorta and the aorta. In the bicuspid aortic valve, we think, the proximal aorta from the annulus all up through the level of the innominate artery is from the same genetic origin embryologically, neural crest cells. So, frequently we see that dilatation go all the way up to the innominate artery, and then it tapers through the arch. And so our default in that situation is to do at least a bevel hemiarch and manage all that tissue in one operation.
Thanks, Dr. Sully. Tom, should aortas be, in patients with bicuspid aortic valve, really be resected at an early stage than a tricuspid aortic valve?
The aorta?
Yeah.
Again, that would depend on the age of the patient, the other factors that would be in consideration, and the pathology of the valve. So I don't think I can answer that as a blanket one way or another. You'd have to further define for me, because frankly, the issues at hand are sex at a younger age would play into it.
Yeah.
Females who want to have children, that would weigh into what we're going to do at that particular index. Degree of aortopathy present as measured by diameter, family history of dissection or aneurysm would play into it. So I qualify the answer simply to say we can't make a blanket statement across all populations of bicuspids, but generally speaking, I would say in the absence of valve disease that we're too aggressive currently, that size alone is not an adequate indicator. There are biomarkers coming down the pike. There are other means of measuring aortic wall disease that we still don't know enough about. The reality is that the guidelines, as you were alluding earlier, are based on very little data and a lot of expert opinion. There are only 2 really good prospective studies that followed bicuspid patients, the Canadian Registry and the Olmsted County 10-year study. Those are the only 2 studies of prospectively followed bicuspid populations, and they would argue that we shouldn't intervene until they're larger than the current guidelines suggest. So I think we're far from giving a broad statement.
Sure. Jabreen, you've mentioned in your talk earlier something very nice that I picked on, that we should respect the aortic root. My question to you is, can we safely repair or replace the bicuspid aortic valve without replacing the ascending aorta, or does this really apply to everybody, in particular to Marfan patients? Can we repair or replace the bicuspid aortic valve without replacing the ascending aorta, especially in Marfan patients?
Yeah, I mean, let's go for the bicuspid valve. In regurgitant bicuspid aortic valve, I think the best, or in our experience, technique to do this repair and have a stable repair, durable repair, is to replace the root and to implant the valve inside of this new root. That's for the bicuspid. Now, to extend it to the ascending aorta, we are reviewing our experience now over the 15 years to see, because we are not aggressive for replacing the ascending and the arch, and we are reviewing all those patients. And the first result, we don't have yet the whole, let's say, statistical analysis, but first analyze, I think we don't have a lot of recurrence or development of a new aneurysm on the distal aorta or the ascending aorta or the arch. So I'm really not aggressive to replace the hemi-arch We replace as much as possible in the ascending aorta while we are assembling the root, but we don't go for unless we have a really aneurysm in this area, we don't go for MERs or
Yes.
for bicuspid. I don't have a lot of Marfan patients, but we follow the same strategy. We stop usually at the truncus.
Okay, thanks, Jibreen. Question to you, Himanshu. What are the risks of late aortic events after an isolated aortic valve replacement for a bicuspid aortic valve stenosis with a concomitant ascending aortic dilatation? What are the risks?
I'm not sure I totally understand the question. So
Yeah.
if somebody has a aortic aneurysm or a
So
slight...
somebody comes to you for an isolated aortic valve replacement for bicuspid aortic valve pathology, in particular stenotic valve, and you would want to operate on this patient in particular, and at the same time concomitantly replace the ascending aorta for a dilatation, irrespective of the size as touched based on by Dr. Bavaria and these members of the panel. What do you think are the risks in your mind that this patient might come back in the future for a redo procedure?
Well, I think the risk, if you take the aorta out of the equation, the risk is more related to what kind of valve you put in.
Yeah.
So, your valve substitute may actually determine the timing of a subsequent operation. I think if you take out the extent of the aneurysm, particularly in some of these patients, as Dr. Coselli suggested, where the dilatation goes up beyond the innominate artery, I think you would likely remove a lot of the risk of dissections. Probably not zero, my guess, but I suspect most of it.
Great. Dr. Bavaria, a question again to you. How would you go, what do you think? Are we pushing the limits for correction of leaflet prolapse and valve-preserving aortic replacement? Is there a threshold or a limit that we should be aware of?
Well, my answer to that question is that we have these regurgitant valves. Historically, we've been replacing these valves. Replacing aortic valves is not without its problems, both midterm and long-term, no matter what prosthesis you use. Most of these patients are young. And I think we need to follow the mitral valve repair paradigm of 20 years ago and start to learn how to repair repairable aortic insufficient bicuspid aortic valves. And I think patients will be better off for it because the only other option for them that is really a good option is the Ross procedure, and the Ross procedure is actually not that great for AI. So I think that we, the community, needs to push this. We need to learn about it. We need to improve it, and we're all following Dr. El Khoury and Dr. Lansack in this regard as we try to create a new paradigm and blaze new paths, and it's incumbent upon us to do this for our patients. I really believe that.
Okay, Dr. Coselli, I haven't heard anything that has been touched base on reduction aortoplasty. Is it something that is out of fashion? Is there something that instigated medical legal problems? But in general, is reduction aortoplasty a safe and durable treatment for borderline dilatation in patients with bicuspid aortic valve? What do you think?
It's probably safe. How durable is questionable because, again, this is another area, as Joe said, that we sort of live in the numerator and don't really see the denominator. Out in our institution, it's almost zero incidence of that particular approach, and so we're not going to have that kind of data, but we do see patients coming to us. We see the numerator where aortoplasties have been done, and they continue to be problematic. They dilate, they dissect, et cetera, and then we're dealing with the secondary option later on. There's some sort of modifications of that. One would be the Florida sleeve, and the other would be the oh God, what is it called? The one with Treasure and those guys are doing.
Yeah, I know what you're talking
yeah, I forget the name of it. Where they do a three-dimensional CT reconstruction and then formulate a device specific for that particular individual that's kind of like a Florida sleeve, but they've used it in connective tissue disorders, et cetera, with some success. I think it's something we have to watch.
Okay, great. Now, just going to push this question to the panel. The answer is yes and no. This is just to determine an overall consensus. The ascending aorta should be replaced less frequently in patients with bicuspid aortic valve. Who's with and who's against? We'll start with you, Joe.
So the question, the motion is the ascending aorta should be resected less frequently than presently.
Yeah.
I agree with Tom Gleason. I think the guidelines are a little bit too aggressive. So I would say it should be done a little bit less frequently than it's done right now.
Dr. Xavier.
Yeah, I agree with that, except I think what's been alluded to and what we're really going to need to be is it's probably overdone in many cases based just on size, but in other circumstances where we just don't have the phenotypic and aortic wall quality data that we need, that maybe in some cases it's probably not done where it should be done.
Thank you, Dr. Sally. Munir.
I would say it's really driven by your own outcomes. I think if you can do it safely, then yes, the answer is yes, you can be more aggressive with it, but you have to really understand what the impact is on the patient in your hands.
Okay, great. Jabreen.
For me, depends mainly on the valve. If you can preserve the valve, maybe you can be a little bit aggressive. If we have to replace the valve, that's another question.
Okay, great. Tom.
Yeah, I agree with the two Joes.
Yeah, I think it's done more aggressively than it needs to be.
Okay, Himanshu.
I think it's done probably more aggressively than it needs to be, but I wonder in this era of whether you believe in TAVR and SAVR, whether, it may be reasonable.
Okay, Professor Siva.
I think we have to adjust it to the patient situation. And in the young patients, we have, for me, we have to be more aggressive because in my experience, over 1,500 patients, the replacement of the ascending aorta has very good results over 10 years now. And with non-replacement, doing nothing with the ascending aorta, we do not know if patients died, if they died from a dissection or whatever, or they died not from the dissection. So I would recommend, in my practice, we are more aggressive in younger patients with a diameter which is out of the normal range with a set value more than 3. And we adjust to the guidelines in older patients, and I think it has to be adjusted to the patient situation.
Okay, touching a few figures on the guidelines. When you look at the literature, which I'm sure the guidelines was based on it, you would notice that ascending aortic aneurysm tends to occur in patients who have an underlying bicuspid aortic valve in the literature between 7% and 79%. So there's a huge skew in the data that is out there. Whereas for an aortic dissection of a bicuspid aortic valve, there is a 9-fold increase of chances for a patient to have an aortic dissection with an underlying bicuspid aortic valve, in comparison to the normal population. Anyway, this is still a big debate. It's beyond the scope of this meeting. I'd like to thank you all for the opportunity to be here today. I'd like to thank once again Dr. Bavaria, Dr. Bidwani, and Prachance for the opportunity to have this discussion and to host CTSNet in this excellent meeting. You've been with Mohammed Bashir, CTSNet Aortic Portal. Thank you very much for joining us.